communities like ours to celebrate the contributions of our people who have come before us. Dr. Knox was 56 when he was tragically killed while riding with his spouse, Mary Beth Kelly, whom we'll hear from in a moment, on the West Side Highway. And as everyone who knows him or knew him will understand, he was really a paradigm, I think, of what it means to be a physician, what it means to be a member of one's community, what it means to be someone who took joy, it seemed, every day in his work and in his life with his family, his athletic endeavors, the care he provided to his patients. It's always fun for me to go back and read about Dr. Knox, as I did in the last couple days in preparation for today, and remind myself, first, as his patient. He was my PCP, and to think about what for me was a really simple but very effective practice that he created here in Manhattan. And I suspect he was in many ways a paradigm of what you'll be talking about later, and that is finding quality in healthcare and quality in the absence of waste, and really doing what's right for patients based on an evidentiary framework versus what we've learned organically or just by tradition. As I say, he took joy in his care of patients, often would visit them at home, riding his bike to see them, took joy in the expertise that he brought to each and every patient, and took joy in being a member of our community as a medical director, as a member of the medical board, as a really cherished colleague to many, many people over the long but still too short years of his career. And with that, I really am delighted to welcome Mary Beth Kelly to join us for a few minutes. As I mentioned, she and Carl were a wonderful pair, have 2 children, and in the years since, Mary Beth has been a passionate and really eloquent advocate for people who get around New York by means other than those that require engines. And Mary Beth, thank you again for being with us this year, and welcome.
Thank you, Dr. Seward. It's, I opened my Zoom and there's this incredible photograph that I love of my husband, and it just, my heart leaps. And listening to your words every year just renews my belief in medicine, that someone like you will, see the value in my husband and want to make sure that this lecture takes place every year, along with Carl and Norma Braun and Maria Samelin. And I just want to thank everybody behind the scenes for making this happen. Thank you so much. And it's not that I just believe in medicine, but I believe in science. And, one of the things that happens that I just want to talk about this morning is that for victims of traffic violence, there is very little justice. And there is also another lingering pain that happens, the additional trauma, that there are no appropriate consequences for the people on the other side of the wheel. And when I say that, I've done a deep dive into something called, unintentional killing. And it happens with guns, it happens on boats, it happens, as a result of being behind the wheel of a car. And there are a minority of reckless drivers who consistently speed and create harm. And we've worked very hard this year at Families for Safe Streets, which is made up of people who have either lost a loved one or have been seriously injured and from traffic violence. And I've been thinking about the unintentional killer, those people who carry a grief and a shame for the rest of their lives for having been one of the people who perhaps through a mistake, but more often because of the absence of really sound, data-proven safety engineering on our roads. And that is as true in New York as anywhere. But in a country that has an average of 36,000 deaths to traffic violence each year. There's probably at least, I'd say 30,000 people who were behind the wheel who are carrying a grief and a shame about that. And we are all kind of in this together, in this divided time that we hope will soon know a sea change, that we all suffer from a lack of the data-driven safety that Vision Zero brings. And if there is a real change in Washington, part of our goals at Families for Safe Streets is to make Vision Zero national. It is good for everybody. And in terms of accountability and justice, one of the things that we have been part of in the last couple of years comes out of the Center for, I'm sorry, I'm blocking the name. It's the Center for Creative Justice, or I'll get the Center for Court Innovation, sorry, where drivers who have committed crimes without a victim participate in a program that borrows from restorative justice principles of reflection and accountability and commitment to behavioral change. And they watch a video that we made with the Department of Sanitation to train, I'm sorry, the Department of Taxi and Limousine Commission to train their drivers. And it tells, 6 of us tell our stories. And the reported behavioral change in these drivers after participating in this is truly significant and lasting. And I just feel that we have a future here, all of us together, to make our environment truly safe for the most vulnerable, the people, particularly in a highly populous urban environment like New York, the people who walk, which is all of us, the people who ride a bike. Micromobility is here to stay, whether you like it or not. There are going to be scooters, on the road. There are electric bikes, it has to be done well, but we all need to be in this, not banning things, but pushing for data-driven solutions that Sweden gave us with Vision Zero, and we need to push for that. We need an administration at the city level who truly funds it, and I hope we'll all get behind that because the suffering and the lives lost and the serious injuries, 4,000 a year in New York City, life-altering injuries, we all deserve better. We all deserve livable streets. Thank you so much.
Thank you, Mary Beth. Thank you very much. And again, thank you for joining us. And it's always great to hear, one, the work you're doing. And I hope you'll share the Vision Zero. We have, all transportation alternatives. We shared that link. We will again this year, but Vision Zero would be wonderful to share that with the audience as well.
Thank you. And if people want to get involved or even just join us, it's pretty inexpensive, but that money goes a long way. And if you go to transalts.org/Families for Safe Streets, you can give directly to our advocacy activist movement. Thank you.
Dr. Sawyer, you're muted.
We are delighted to have Dr. Deborah Korenstein with us today, who is professor of medicine at Weill Cornell Medical College, as well as being the chief of the General Internal Medicine Service at Memorial Sloan Kettering Cancer Center, where many of our trainees go, as everyone will know. And hopefully, Dr. Korenstein, they have the opportunity to brush shoulders with you when they're rotating through. She's also the past editor-in-chief of ACP's Smart Medicine. She received her BA from the University of Pennsylvania and her MD from the College of Physicians and Surgeons of Columbia University, and then completed her internship and residency at Beth Israel Hospital in Boston. In the years since, she's really been a wonderful force in helping us better understand how we bring both value and how we counteract overuse in healthcare. And as I mentioned, I think all of us will agree what we do each day for our patients in terms of the labs that we order, tests that we order, sometimes there's a wonderful evidentiary basis for it. And sometimes it's really because maybe someone like me, you saw me doing that with my patients and figured, well, if Samuel Stewart does it, maybe that's the right thing to do, without really knowing first whether that particular test has value for that patient, and even more importantly, whether in doing that test we potentially put our patients at risk of harm. I can't imagine a better setting to try to pursue this work than MSKCC, and Dr. Korenstein has made tremendous advances in understanding what's the best care for cancer patients. And in doing so, really has taught generations of learners how to go out in the world and certainly bring value, certainly save expenses for American healthcare, but as I say, most importantly, to provide even better care for our patients and even safer care for our patients. Dr. Korenstein, we're so privileged to have you today as our Knox Memorial Lecturer, and thank you.
Thank you so much for that incredible introduction, and thank you for having me today. I'm honored to be able to speak at this important event. I didn't have the pleasure of knowing Dr. Knox, but I think that he was somebody who would have fretted about his patients' drug costs, which is what I'm going to talk about today. And I'm not actually going to talk about overuse per se, but I am going to talk about value. And I was struck by something that Mary Beth Kelly just said about the importance of making our environment safe for the most vulnerable. And I think talking about the cost of drugs is an important way to make our or lowering the cost of drugs is an important way to make our environment safe for the most vulnerable patients. So I'm going to share my screen.
Yep.
Can you all see it?
Yeah.
Okay. So I personally have no relationships with any for-profit entities, but my spouse does. He serves on 2 boards and does consulting for Takeda, none of which I really understand, so I don't think it biases me in any way. Oops, wait a minute. Okay. So what I'm going to talk today about is drug pricing, and I'm going to start out by just giving a little bit of background about drug spending and drug prices. A word about how we and our patients experience drug prices. I'm going to spend most of the time talking about why prices are high, because it's actually kind of complicated, and then get to some proposed solutions. So this slide shows per capita drug spending in the United States compared to other countries. And I think everybody is probably very familiar with this data, which shows that we spend much, much more in the United States than any of our peer developed nations in Europe, Asia, and elsewhere. So that, I think, is not news to anybody. And similarly, I think it probably isn't news that spending has risen really rapidly over time, as you can see in this graph. So you can see starting in maybe the late 80s or maybe 1990, spending really started going up astronomically compared to the kind of low rate of increase that we see before that. And this happened, the rise happened in all countries around the world. This compares the US to other developed countries. But you can see that we're the orange line here. Actually, use my pointer. We're the orange line here. You can see that starting in the 1990s, the rise was much more rapid in the United States than anywhere else. And I think it's interesting to look at the fact that before 1990 in here, we were really just part of the crowd. The drug prices in the United States were not higher, or drug spending, I'm sorry, in the United States was not higher here than it was elsewhere. And then something changed in the 90s. And I don't know what that is, so don't ask me. I'm not going to cover that because I don't think anybody really exactly knows what it is. It's probably a confluence of many different forces. So I have 2 kind of audience response questions in this talk. So this is the first one. And, oh, David, thank you. So the question is, why is US drug spending so high? And your 4 options are lower use of generics in the US, high rates of prescription drug utilization across the board compared to other countries, high cost of individual drugs, or all of the above. And I'll give everybody about maybe 30 seconds to give your answer. All right, you probably don't even need 30 seconds. All right, David, do you have a good number of responses?
Stop the polling, and I'm going to share the results.
Okay, so all of the above is the winner. And that is not the correct answer. Actually, can I close this? Oh, beautiful. Okay, the correct answer is higher cost of individual drugs. And I'm going to show you some of the data on this. So it turns out that our overall utilization is about the same of prescription drugs, is about the same in the United States compared to other countries. I mean, we're on the higher side. Here we are over here compared to other countries. And this is just, this number doesn't mean anything. It's just the ranking of where we are, of where everybody is. But you can see, you know, we're similar to other developed countries, and even the ones that are on the lower end are not that much lower than where we are. And this is always interesting to me because, as Dr. Seward said, I spend a lot of my kind of energy thinking about overuse and unnecessary care. And I feel like our use of pharmaceuticals is higher than it might be in other places, but it turns out that it really is not. And similarly, this may be surprising to a lot of people, we are very high users of generic drugs in the US compared to other countries. So what this graph shows you is the percentage of prescription drugs in each country that are generic, so which is the share of generics in the pharmaceutical market. So you can see that we are at the top and really substantially better than a lot of other developed countries in the use of generics. So, and I think there's been a big push in this country for at least over a decade toward generic drugs. And I think that it has worked, which is really good news. But it turns out that the amount we pay for each drug is far higher in the United States than it is elsewhere. So this shows you the comparative cost of a drug in the United States in black compared to in other countries in the world in blue. And you have to be a little careful because the specific y-axis is different for different drugs. So you can see that for Crestor, it goes up to 220, and for this hepatitis C drug, it goes up to 30,000. So the y-axis is quite different, but the comparison still holds. And you can see that for commonly prescribed drugs, like drugs for cholesterol, for diabetes, for asthma, these are all the brand names because that's the way the prices work. I normally don't use brand names in talks, but in this case, it is very relevant. Prices are much, much higher. The monthly price is much higher in the United States than elsewhere. And that's also true for very expensive injectable drugs and specialty drugs. So across the board, really, for most drugs, the cost of a month of drug is much higher in the United States than it is in other countries. So why does this matter? And I'm not going to say much about this because I think everybody knows, but you know, medical issues are the @1 cause of bankruptcies in the United States. And this is all pre-COVID. God knows what's happening now. And at least pre-COVID, medical expenses were responsible for about 2/3 of bankruptcies in the United States. And I think we all know that the cost of drugs contributes to this. This is a study among US adults. So this is among people who take drugs, about 25% of them report having difficulty paying for them. And I think for those of us who see patients, we've all seen this in action. I mean, we all know patients who can't afford all their drugs and pick and choose which ones to take for months at a time or even chronically. This is clearly a very big problem, and it's a problem all across the country. And it can lead to non-adherence. So this is data on cost-related non-adherence in older adults across developed countries. And the bar is the odds ratio compared to the UK, even though it doesn't look like it's at 1 there. But that's an odds ratio compared to the UK. And the line is the percent of older adults who report cost-related non-adherence. So you can see in the US, about 17% of older adults report that they sometimes don't take their medication because of cost. And that represents a 6 times higher rate than what is seen in the United Kingdom. Again, I think not at all surprising, and something that all of us as clinicians have experienced, but still, kind of remarkable to see how high it really is. So I'm now going to spend some time talking about why prices are high in the United States, because it's, as I said, rather complicated. And that brings me to question number 2. David, can you bring up question number 2? So what is the most important driver of high drug prices in the US? Is it the cost of advertising and detailing, high drug development costs, government inability to negotiate price, or middlemen in the marketplace? I'll give you, 30 seconds.
Okay, I'm going to stop the poll.
Okay, great. Oh, so we got some nice spread here. So we're kind of evenly divided here. Nobody thought that cost of advertising and detailing is the most important driver, and you're right about that. And then I think more people say government inability to negotiate price. And then we're pretty much tied between high drug development costs and middlemen in the marketplace. So I would argue that the correct answer is actually middlemen in the marketplace. These factors may all be kind of at play, but I'm going to show you why I would argue that middlemen are really the most important reason for high drug prices. In order to understand all of this, you need to understand the supply chain of drugs. And in the United States, there are 2 different supply chain systems. I'm going to spend the most time talking about prescription drugs. So these are drugs that a patient gets a prescription, goes to a pharmacy and gets the drug, generally pills, but they could be injectables as well that people take at home. And then there are outpatient drugs that are administered in doctors' offices. And I'll touch on that at the end, but I think the world that most of us live in is the world of prescription drugs. So I'm gonna focus mostly on that. So to understand this, we need to understand the different stakeholders. And so I'm going to walk you through who these different stakeholders are and then how they interact with each other. So some of these are things we're all familiar with. So obviously the pharmaceutical company is the manufacturer. There is the pharmacy where the patient gets their drug. There's the health insurer that in some fashion pays for the drug, one hopes, and then there's the patient who is getting and taking the drug. And there are 2 other stakeholders in this universe of pharmacy drugs. One is the wholesaler. So what wholesalers do is they distribute drugs to pharmacies and other entities that might, in the supply chain, that might in turn sell them to patients. And they basically just are like pure middlemen. They buy the drug and they sell it to other people. And there's also the pharmacy benefit manager. And their job is to negotiate, basically to create insurance plan formularies. And I'm going to just tell you a little bit more about PBMs, or pharmacy benefit managers. The 3 largest in the United States that cover most US patients are Express Scripts, CVS Caremark, and United Healthcare. So these are companies that we have all heard of, obviously. So what happens is the insurance company, the insurance plan, hires the PBM to negotiate on their behalf in order to lower drug costs. And this started happening in the 1980s, and then it has really taken off since then, such that it's pretty much a universal phenomenon now. And I think we all see this when we prescribe drugs. We see that a lot of our patients, it goes through CVS Caremark or Express Scripts or whatever. So we kind of see this as clinicians. So the PBM then, once they've been hired, negotiates with the manufacturer. And the manufacturer uses rebates to entice placement on the formulary so that the patient has kind of easier access to their drug. The PBM also negotiates with pharmacies about the pricing of those drugs, basically, and how much the insurance plan will reimburse the pharmacy. So in order to understand how it works, I'm going to kind of walk you through this. And it's really complicated, and I know a little bit hard to absorb, but it's kind of incredible once you understand it. So what we're going to do is start up here with the pharmaceutical company. And they start by setting a price for their drug. And so we're going to follow actually both the drug and the money through this system. So they set the price of the drug that's called the wholesale acquisition cost, or the WAC. So I'm going to call that WAC. So the wholesale acquisition cost is set by the company. The wholesaler then buys the drug from the company for usually the WAC minus some kind of a discount, because there's a negotiation that goes on between the two of them. The wholesaler then sells the drug to the pharmacy for a negotiated price. And pharmacies actually, the numbers that I have when I show you numbers in a minute don't reflect this because they're made up, but that price is usually a little bit above the WAC. So the wholesaler then, makes a little bit of money on this whole interaction. So the patient then goes to the pharmacy and pays their money, which is either a copay, which is a flat fee. So that's where patients have like tiers of drugs where this tier is $10 flat fee, this tier is $20 flat fee, et cetera. Or coinsurance, which is a percentage of the cost of the drug, which has become increasingly common over the last several years. I would say that copays used to be more common, and now coinsurance is more common. So the patient pays their copay or coinsurance to the pharmacy. The pharmacy is then out the rest of the money because they've purchased the drug from the wholesaler. So the PBM reimburses the pharmacy for essentially the remainder of their cost plus a dispensing fee, all of which had been negotiated beforehand. And the health insurer reimburses the PBM for that money as well, and they also give them a service fee on top of it. At the same time, the pharmaceutical company has given a rebate to the PBM, which was part of their negotiation about the price of this drug, most of which then flows back, I lost my mouse, to the health insurer. So most of that rebate goes back to the health insurer. So there's a lot of money kind of sloshing through this system. And I'm gonna try to illustrate that by showing you what happens with the money. So let's say the WAC is $100, so that's the price. The wholesaler buys the drug from the pharmaceutical company for a little bit less than the list price. The pharmacy buys the drug for a little bit more than that. And in real life, it would actually be more like 105, not 95. Sorry about that. It was actually very hard to make up numbers that would work well. The patient then goes to the pharmacy to fill their drug. The pharmacy sets a price for that patient, which I actually forgot to mention on the previous slide. And they set that price differently for patients with different insurances. That's part of the negotiation as well with the PBM. So, whoops, I didn't mean to do that yet. So the patient then goes to the pharmacy. There's a price that's been set for that patient. The patient, let's say in this case, pays a 20% co-insurance, which is $24 in this case. The pharmacy is then out the rest of the money. They get reimbursed by the PBM for $96 plus which is what they're out plus a dispensing fee. The health insurer reimburses the PBM for that $96 plus a service fee of $10 in this case. And at the same time, the pharmaceutical company has paid a $25 rebate to the PBM, which gives $20 of it back to the health insurer. So at the end of the day with this drug, here's where everybody is. The pharmaceutical company makes $65. The wholesaler makes $5. They work in volume. Wholesalers handle a huge volume of drugs. So the way they make money is by they make a little bit on each one, probably a lot less than this, but they handle a lot of drugs. So they make money. The pharmacy has made $25. The PBM has made $15. The health insurer is out $86, which is a good deal for them compared to the list price of $100. And the patient is out $24. So you have to realize all of these negotiations are occurring separately and everybody's jockeying to make money. And sometimes people talk about specific strategies for making money. So I just wanted to mention one of them that you may read about in the newspaper even, which is called spread. So spread represents the amount of money that the PBM makes because it's the difference between what the plan pays and what is reimbursed to pharmacies. So spread is the amount PBMs retain as their profit when this all happens. So if the insurance plan pays the PBM 100 and the PBM pays the pharmacy 90, that's the spread. And I called that, I think, a service fee on the prior slide. But one of the important things to know is that spread can be enormously high. It is commonly a few $100s, but it can be as high as $2,500. So PBMs are making a lot of money, but really so is everybody else. So this shows you how much money each of these industries is making in the United States per year. So obviously, I think we all know that drug manufacturers make a huge amount of money. It's the, I think, second largest industry in the United States, second to oil. But that is from a couple of years ago, so I wouldn't be surprised if it was now the number one industry in the United States. Wholesalers are also making a lot of money. You can see that second to manufacturers are pharmacies. I don't think everybody realizes how much money pharmacies actually make when they fill drugs. And also PBMs, which are just pure middlemen and really aren't adding any value to this system, are also making a lot of money. So basically everybody is making money off of this system. So I want to talk a little bit about when this gets really out of whack. So I want you to imagine a competitive market. So I don't have an audience response thing for this, so you're just going to have to imagine in your own head. So imagine you're a drug manufacturer with an old but still brand name product that has new competitors in the market. What can you do to maintain your primacy? So, and a great example of this is insulins, and I'm going to show you some data on insulin, on the pricing of different insulins in a minute. And I'm going to so imagine all these new insulins have been released. Let's imagine that you're the maker of Lantus, which was, let's say, the first longer acting now of several on the market. So if you think about it, if you want your drug to stay competitive, you need to make your product top tier in the formulary for lots of different insurance plans that cover the most number of people. And the way you do that is through rebates. So I said before that PBMs negotiate with pharmaceutical companies to get better prices for the health insurers. And the carrot that they have is the formulary. So the PBM says to the pharmaceutical company, well, if you give me a bigger rebate, if you discount this drug more for me, but really or if you give me a bigger rebate, I will make this top tier on my formulary. So what the pharmaceutical company can do is ramp up the rebate. And what they do when that happens is they just jack up the price of the drug to reflect those rebates. So I had this drug priced at $100 in the previous example. If you jack up the rebate, they will just jack up the price, let's say now, for example, to $280. And then if you then follow the money that flows through this, and I would mention as an aside that rebates for insulin are about 66% of the price of these high-priced insulins. So the price, the WAC is largely made up of rebate prices. That's how much the rebates are going to PBMs. That's about what it is in this case. In this case, it works out to be about 70%. And that's pretty much reflects what happens with insulins. So here's what happens to all the money flowing through the system. And at the end of the day, plenty of time. At the end of the day, if you look at how much money everybody is making and losing, essentially the PBM makes a little bit more than they made before. The patient is out a lot more than they were before if they're still paying that 20% co-insurance, and everybody else kind of stays about the same. So this is really the key to what has happened in the United States, is these rebates have pushed prices up so that patients are paying more, PBMs are making a lot of money, and everybody else is kind of staying about the same. So there's no real driver for them to change the system. But it's patients at the end of the day who really suffer for this. And you can see this if you look at the prices of insulins. So you can see that beginning in the early 2000s, when these new insulins were introduced, you can see the price of all of these insulins starts to rise, close to exponentially. And it's all because of rebates. I want to say, as kind of an aside, that this has continued during COVID. There are 245 drugs for which prices have been raised since during the COVID pandemic. Some of them are used for the treatment of COVID itself. And I think we've all seen this, including steroids. Prices of steroids have gone up. some drugs that have been used in clinical trials, and then even drugs for chronic conditions, including, you can see below, cardiovascular drugs, cancer drugs, like all kinds of drugs. And so this is something that just goes on unabated despite, a major crisis. I want to say a word about copay coupons because they do play a role, and it's not something that's really part of the ecosystem per se, but it is part of some of the solutions, or stopping it is part of some of the solutions. The bottom line is these copay coupons allow overpriced drugs to seem more affordable, which in my opinion kind of enables perversity in the system. But what they do is they are created by the manufacturer, or sometimes even by the PBM. They go directly to patients, and they allow patients to get help with their copay. Sometimes you can't use these if you also use your insurance to pay, so they get very complicated. But essentially, they're just a perversion that allows it to seem like the patient doesn't have to pay so much for a drug, but still most patients aren't using a copay coupon and continue to have to pay a lot for drugs. So back to our competitive market, what the copay coupon does is it impacts this part down below, which I've highlighted in yellow, where the patient has to pay. And it just allows all of this other money to continue funneling through the system. And copay coupons are very common. So I want you to focus on the green kind of triangles and diamonds here that shows the percent of prescriptions that are filled that have copay coupons. And you can see in 2017, it was 18%. This is the most recent data that I could find. But it turns out that over half of coupons, 53%, are for drugs that have a generic equivalent. So they're enabling people to pay for a brand name drug when they could be they could be just using generic drug instead. So again, kind of a perversion in the system that allows this craziness to continue going on. So all of what I've said really applies to branded drugs, not to generic drugs. But as I showed you, a huge number of generic drugs, drugs in the United States are generic. So what about generic drugs? So like I showed you before, they're very commonly prescribed in the US, and they make up a smaller share of spending because they indeed are less expensive. So 80% of prescriptions, but 20% of spending. And indeed, generic drugs are much less expensive than brand name drugs. So this shows you the price of generics and brand name drugs over time between 2013 and 2017. So in the blue bars, you can see the price of brand name drugs continue to rise pretty rapidly. And you can see that the overall price of generic drugs has gone down, which is a good thing. And what they're focusing on here is the ratio, showing you that the difference in cost between brand name drugs and generic drugs, it has gotten greater and greater over time. But I think it's important to recognize that there are exceptions, and some of them are very famous exceptions. So if you look at what happened to the price of generic drugs, this is just for 2017. So you can see in these lighter colors, most generic drugs on the market that year actually went down in price, which is a good thing. However, there are some drugs that increased in price, and there are some that went up a lot. You can see these are smaller chunks, but there are some drugs for which the price of the generic increased a lot. And so I just want to talk for a minute about what's going on there and why that is happening, because I think we've all struggled, and I'll give, I think, one example that'll resonate with people. We've all struggled with understanding this as clinicians when it happens. So this is cartoon villain Martin Shkreli. He's kind of the poster child for this. He is the founder and CEO of Turing Pharmaceuticals, which is the manufacturer of Daraprim, which is pyrimethamine, which, as you all probably know, is a drug that's used to treat toxoplasmosis, which is a relatively rare disease. So Martin Shkreli bought the company, or his company, which is really him, bought the company that owned the rights to this drug. And very famously, they then proceeded to jack up the price 750-fold. So prior to this, pyrimethamine was dirt cheap. It had been around forever. it was just not an expensive drug. And they initially raised the price a little bit and then astronomically to a peak of about $750 per pill, which is, obviously totally outrageous. They then lowered the price a bit in response to basically public outrage, but it still remained much, much higher than it was and than it should be. So why does this happen? Essentially, they were able to do this because there was almost no competition. There were basically nobody else made this drug because there was not a very large market for it. And there was a lack of alternative therapies. So if a patient actually had toxoplasmosis, they needed this drug. And the reason they get away with this is it just doesn't make sense for another company to invest in ramping up manufacturing in order to provide a competitor, when that company knows that if they did that, the price would obviously go down. And so, it costs a lot of money for a competitor company to start manufacturing a drug. So that's why, they basically got away with this. A similar thing happened with EpiPen. And that may be something that people have noticed. And I know that I had patients who, told me like they can't afford to buy their EpiPen anymore all of a sudden. EpiPen is actually really interesting. It turns out the generic is made by the same company. So you can see here that the price of EpiPen went up astronomically, and in 2016 went up to $600 for an EpiPen. The generic is not that much cheaper. It's also about $400 for a pack of two pens, which is, really crazy and life-threatening. But again, this is a company that doesn't have a lot of competitors. And I think in particular for EpiPen, the delivery system is kind of complicated and might even be patented. And so it was difficult for other people to make this drug. And there are some other examples of this with expensive generics. Nadolol, the price rose a lot from about a couple of years ago from about $10 to $200. Haloperidol went up in price, and sildenafil, which I think this probably happened after it became the standard of care for pulmonary hypertension, but it now costs $279 for a 30-day supply, even though this is a drug that's been around for quite a long time. And the other thing is there's been some craziness with albuterol inhalers as well. So this is something that happens very commonly to individual drugs, and that I think patients for sure feel. And I mean, I've even felt it as a clinician and often wondered like, what is going on with whatever drug. So I'm going to switch gears now to talk a little bit about outpatient drugs. And these are drugs that are administered in doctors' offices, like I mentioned before. And they have a slightly different set of stakeholders that I'm going to go through. So obviously still the pharmaceutical company, still the health insurer, still the patient, and still the wholesaler, which does basically the same thing that they do for pharmacy drugs. They buy the drugs at the WAC minus a small discount, which they negotiate. In this universe, though, we also have group purchasing organizations. So these are companies that aggregate purchasing volume across multiple providers. Because remember, there are a lot of individual doctors giving these things in their offices. So they then negotiate with wholesalers and pharmaceutical companies. The most important thing, though, about this to know is that the doctor's office for these drugs is reimbursed based on the price of the drug. So if a doctor is giving one of these drugs in their office or a hospital, they will make more money if they administer a higher priced drug, which, in my kind of world of thinking about unnecessary care and value, this is just an absolutely insane incentive to incentivize doctors to use a higher priced drug. And again, I'm not saying that any doctor, I really believe this, I don't think any doctor does that intentionally, responds to that incentive by saying, okay, like to consciously say to himself or herself, if I give this drug, I'll make more money than if I give that drug, so I'm going to give the more expensive drug. But I do think that there's a lot of evidence from the social sciences that financial incentives influence people, and they do it in a subconscious way, despite the best intentions. But it is just simply crazy to set up incentives that incentivize people to use the more expensive drug. So to summarize the issues at play and the pricing concerns by drug type, starting with prescription drugs, these are drugs dispensed at the pharmacy. The payer reimburses the pharmacy at a negotiated rate based on the list price, but there are a lot of other players in the system that lead to what I think I would call perversions. So in a competitive market, PBMs, the power of PBMs drives rebates up, which leads to high prices for everybody and more profits, incidentally, for the PBM. Not necessarily more profits for the pharmaceutical company, because they're paying out a lot of that money back to the PBM. In drugs without competition, a manufacturer is incentivized to set a high price. And in that case, it's not the PBM profiting more, it is indeed the manufacturer. And generics are generally of lower price, and I think we all know that, but lack of competition for individual drugs can drive prices back up. And I gave some examples here. I didn't mention before HIV drugs, but one of the things that keeps HIV drug prices high is that by law, they have to be included on everybody's formulary. So there's a lot of power. The pharmaceutical companies have a lot of power in that case to keep the prices high because everyone has to put it on their formulary. Like the PBM loses its negotiating power because it's going to be on the formulary no matter what. For outpatient drugs, and the prime example of this is cancer drugs, there are also a lot of rheumatology drugs now that are given in this way. These are administered in doctors' offices and outpatient clinics. The payer reimburses the prescriber based on the price of the drug, which is a little bit more complicated than what I said before, but essentially it's just the price of the drug. And that leads to incentives to select more expensive treatments. Okay, so now I'm going to switch to proposed solutions and talk to you about what's going on a little bit at the federal level, which is not much, and the state level. So these are the concepts when it comes to policy solutions for this problem. And I have divided these into 5 buckets. Some of these are regulatory and some relate to tweaking some of the incentives. So first, under the bucket of improved competition, there's the concept of limiting market exclusivity, which would allow generics to come to market more quickly, create competition, and drive prices down. And similarly, there's the concept of reducing costs to develop generics in a variety of different ways. I think that those have not gotten a ton of traction so far. There's the bucket of government interventions. So when I asked before about why prices are high, many of you marked that it was because Medicare is not allowed to negotiate prices. And I think that there's a lot of truth to that. That certainly would help. So there's kind of the obvious solution of allowing Medicare to negotiate prices, which a lot of people are talking about. And there are also government interventions related to regulating PBMs, which have become very popular to, but it could work, I guess. I don't know that, it seems rather complicated to me to do it this way. And probably doesn't fix the underlying issues, which I'll go into a little bit. At the physician level, there's a lot of call for price transparency. So that's at the level of ordering. So when you go into your EMR and you order a drug for a patient, it would tell you how much that drug costs. And there are actually a number of studies of this that have, I would say, mixed results. There are a couple of studies that have shown that price transparency does sort of push physicians toward prescribing lower priced drugs. And there are some that show that initially it does that, and then people, like everything else, they start to ignore those numbers when they come up, and then things kind of go back to the mean. The other real problem with price transparency is it is so complicated and it is constantly changing. So I think, again, we all know from our patients or even from ourselves that the price constantly changes for reasons that aren't clear. It's different for different patients. So it involves a lot of complexity on the part of the EMR to know what the price is for this patient today based on what insurance they have. And for people with multiple insurance plans, it gets super complicated to figure out which is their primary, how is their drug being paid for. So then you end up showing price transparency for like the list price or something like that, something that is the same for all patients. And again, that may not be very relevant for an individual patient. So it gets really tricky to implement price transparency, even though I think in theory, it's the right thing to do. I think doctors should know the price of stuff they're prescribing, but it's really, really hard logistically in the real world. There's also this real interesting idea of tying payment to doctors to their drug expenditure. The idea is that doctors get reimbursed from an insurance company based in some complicated way on how much they spend in total on drugs. And that the idea of that is to incentivize doctors toward lower priced drugs and generic drugs. I mean, I think nobody has really ever done this. And I think it probably would likely be unfair. You know, it would probably penalize doctors for having certain kinds of patients. And so I'm not sure that that's ever going to really happen. At the patient level, there are various cost shifting schemes, and this has been going on for a really long time, trying to have different copays and different ways, like a copay versus a coinsurance. I think the idea of coinsurance is that patients would ask doctors to prescribe lower cost drugs for them. And I don't know, maybe it works. I think sometimes patients do come and say like, okay, this statin is, will be less expensive for me, and then you can swap it out. But the examples of completely equivalent drugs there aren't all that many. And I'm not sure, I think the evidence does not really show that these strategies work particularly well. There's also something interesting called value-based insurance design, which I think already exists to some extent. It's the idea that patient cost is going to be lower for high-value services. And I think there are some very simple examples of this, like patients don't have to pay anything for vaccines, and in many insurance plans for screening tests. And I think that's based on this concept that these are things that are of high value. We want to incentivize them by not having any financial disincentives. Once you start getting into the specifics of drugs, I think it gets a bit more complicated, but I think people are playing around with various ways to do that. And then finally, there are strategies that are focused on value a bit more broadly. So one thing that you may read a lot about, which I think is a little bit controversial, is outcome-based contracting. So the idea of this is that you align costs with individual or group clinical benefit. The idea is that for a particular insurer, if their patients don't benefit as expected from the drug, then the manufacturer gives them a rebate. So they're going to buy this very expensive drug for hepatitis C, and if fewer patients than expected based on, I guess, theoretically the evidence or what the manufacturer promises, if fewer patients benefit than that, then the insurer gets some money back for the cost of that drug, from the money that they spent on that very expensive drug. So there are some plans that have been doing this and trying it out. I think we don't really know yet what the final verdict is on whether this works. It seems a little bit strange to me because, there are very few drugs for which every individual patient is expected to benefit. And there are a lot of things that could come into play. And it just makes more sense to me to right size the price of the drug for everybody rather than have these complicated schemes. But this is something that people are looking at. And then finally, value-based pricing. So this is the idea of changing the price of the drug for everybody, not based on how individual patients respond, not based on their insurance, but just setting the WAC at a number that makes more sense. And I'm going to say a little bit more about that. And I want to take a little step back. The way I got involved in this is through working with Peter Bach, who is a health services researcher at Sloan Kettering, with whom I now work pretty closely. And he's very into researching solutions and policy solutions to high drug prices. And he has something called the Drug Pricing Lab. And he has really pushed the idea of value-based pricing. And I think there are others. There's a group at University of Michigan who also is very into value-based pricing. There's some other groups around the country. And as people have talked about policies around this, this is one of the important ones. So this is something that I adapted from the website of the Drug Pricing Lab. The Drug Pricing Lab is partially grant funded, and part of that grant is an educational side. And I've been leading the educational efforts around this. So that's why I kind of have this talk. So anyway, so this comes from the Drug Pricing Lab. And if anybody's interested, you can go there and play with an abacus where you basically set how much you value each of these factors, and it helps you calculate what the price of the drug should be. But I'll talk about it in more of a big picture way. So the idea of this is that there are a bunch of factors that should play into a drug price. The way it works now is essentially the manufacturer just makes it up. They just decide what a drug is going to cost. They may claim that the cost is related to their development costs or whatever, but really it's based on what the market will bear. And that's the way it has worked. And there's something a little bit weird about that because healthcare is not a normal market. So the idea of value-based pricing is that you take all of these different factors into account, and you might value some more than others in different situations. And that's why on the website, you can sort of move a little bar to say how much you value each thing. So and I'm just going to tell you what each one kind of means. So the toxicity discount means that the price would be lower if there are severe side effects of a drug. And again, you can decide to what extent you care about that. There's a novelty multiplier that means that we are willing as a society to pay a premium for a novel mechanism. And I think that's kind of a way of rewarding drug companies for innovation, which is what they say, like, we need to have a system that rewards innovation and allows us to get a higher price. So that at least allows you to play around with how much you're willing to, allow them to charge more based on novelty. There's price for a year of life saved. So that's, as a society, we can set the value that we would place on a year of life. And we can kind of flip that around. And I mean, the classic example of that is we as a society in the United States, we don't officially do this, we're kind of not allowed to. But if you think about cost effectiveness, we generally accept things that have a value at or better than $150,000 per year of life saved. In the UK, that number is closer to something like $80,000 per year of life saved, and they actually are explicit about that in their national health system. But in the developing world, there just isn't money to pay for that, and so the threshold in the developing world might be $5,000 per year of life saved. So again, you can play with that to factor into the drug price. There is the rarity multiplier, which would allow you to enable higher prices for a very rare disease because there's less volume of drug that's likely to be sold. Or kind of on the flip side, you can look at population disease burden, which allows you to price a drug differently based on the population health burden. There's the cost of development, which it would be, not just overall the company's cost of development overall, but the cost of development of this drug. There's prognosis that would allow you to enable higher drugs for more aggressive diseases. Maybe we're willing to pay more for that. And then unmet need. If there are illnesses with few other treatments, maybe, we would allow a company to price the drug higher. But this is something that ultimately society really should be determining in a way that is transparent and makes sense. And it's not something that we have really ever accepted in our society, but I think that it makes more, right now it's completely arbitrary, so at least it makes sense to think about what the factors should be. So I'm going to close with policy solutions that we've seen, and I'll start with the state level solutions, and then I'll talk about the proposals at the federal level. So states can only do certain things. I mean, there are many ways in which they don't really have the power to regulate the whole industry, but there are things they can do. So some of those proposals have focused on transparency, where the company has to report price increases so at least people know when it's happening. States have experimented with allowing some importation of drugs, so that's been interesting. They have regulated PBMs, a lot of which has just been around transparency. And they have implemented for their Medicaids, which they can control, obviously, because those are run by the state. They have been overseeing the pharmacy benefit designs and not just outsourcing them to PBMs. And they have done some value-based contracting. They've done kind of a little bit of value-based pricing in Medicaid, but mostly it's been contracts at the broader scale. So this map just shows you some different state actions across the country. And the point really is that there are a lot of different reforms that are shown here with the different colors. of dots, and I guess some of them are, I guess they're all dots. And these are taking place across a lot of states. Both red states and blue states are doing some of these things to try to bring drug prices down, because the states really feel it through their Medicaid systems. They really feel high drug prices. So there really is a lot going on at the state level that if you read about this, you know, you're generally hearing the news at the federal level. So it's encouraging, I think, that there's stuff going on at the state level. So fortunately, I guess, we have an election coming up. So unfortunately, though, today I still have to show you both of these proposals. The Trump administration has issued a couple of executive orders to make what I would call kind of relatively weak attempts to address this problem. But I'm going to go through these different kind of components of the two proposals from the administration and also the Biden campaign. So the Biden campaign has proposed allowing Medicare to negotiate prices, which has been a part of the Democrats' proposal pretty consistently. The Trump administration does not want to do that. There are a bunch of things related to the international market. So both groups want to allow drug importation, and also both groups have some kind of proposal to anchor prices to prices in other countries. And the details differ, but the concept is essentially the same. Both groups have proposed limiting price increases in some way to inflation. The Biden campaign has proposed this much, much more broadly than the Trump administration, to basically apply to everything, including some generic drugs, whereas the administration proposal has only limited price increases to Medicare Part B drugs. So other issues related to Medicare Part D, both groups have proposed capping out-of-pocket costs for Medicare recipients, which is good. The Trump administration also wants to ban rebates, or they also at some point had a proposal to make rebates go directly to patients as opposed to PBMs. The Biden campaign has not proposed banning rebates, interestingly. And then there are some regarding direct-to-consumer drug advertising, which I have not talked about much. I think direct-to-consumer drug advertising is super interesting. And so I can't help myself but say a word about it. We are one of only 2 countries in the world that allows direct-to-consumer drug ads. It is the United States and New Zealand. And there is evidence that is hard to come by because it's kind of internal evidence from the manufacturers, but it is very likely that direct-to-consumer ads work. And I think as clinicians, we have likely all had the experience of patients coming in asking us about advertised drugs. Another interesting thing about drug ads is I think very often they're targeting the doctor who's also a consumer, you know, and sort of getting them used to the drug. And it's probably a better way to reach doctors than direct to physician advertising in some ways. There are multiple studies showing that direct to consumer ads are misleading, not surprisingly, but they definitely work. And it always amazes me what drugs they're advertising, like antipsychotic medications. Like, is that really working? Or, you know, third line antineoplastic drugs. Like, I don't really get it, but it works. So in terms of drug advertising, the Trump administration wanted to require prices on direct-to-consumer ads, but that was struck down in federal court, so that is no longer really in play. And the Biden campaign has proposed eliminating a tax break for advertising. And this seems like a no-brainer to me. Apparently, manufacturers can deduct the cost of direct-to-consumer ads from their taxes, which I don't really understand. But the Biden campaign has proposed eliminating that, which I think would make sense. And so this is just another plug for the website that I mentioned before. The Drug Pricing Lab has a policy tracker, as well as the Drug Advocacy, where you can play around with drug pricing, where it basically tracks a variety of different policy proposals and kind of what's happening with this. So if you're interested, you can find that all summarized on the website. This is good timing. We have a few minutes left for questions. So in summary, drug prices are high in the United States. And high drug prices are important because they impact adherence and they definitely harm patients, both financially and in terms of health through that poor adherence. High prices are largely driven by a complex system with a lot of middlemen, and there are a lot of proposed solutions. I think the jury is out on what solutions are the best ones, but I think it's encouraging that there's a lot of talk about this problem on both sides of the aisle, and a lot of possible solutions that may help. So I'm going to stop there and take any questions that people have.
Thank you for the talk, Dr. Korenstein. We're going to open the floor now for questions. Whoever wants to ask a question, just unmute yourself. On the chat, just Norma Braun said, the pressing sense of helplessness in your being able to affect the cost of drugs. So if anyone has any questions, please unmute yourselves and we can start discussing for the last few minutes of my rounds.
I mean, I think I just want to address that while people maybe think. I think it's very easy to feel helpless about this. It's easy to feel helpless about so very many things in the world right now. I think one of the encouraging things is that, doctors can be advocates for these kinds of things. And even just to know about this enough to talk to individual patients about it, I think is helpful and can empower us and help empower our patients. So I would encourage you to, hopefully you've learned something today, but, to read more about this and understand it so that you can help your patients navigate it, and even to advocate, to government at whatever level you want to address it.
Deb, I have a question. This is Yusuf Ali. We miss you at Sinai.
Thank you. How are you?
I'm good, thanks. Quick question. This might be a bit cynical, but do PBMs or insurance companies have any influence over Epic? And the reason I ask that is because I got a pop-up recently when I prescribed hydroxychloroquine saying, you've selected a generic. In order to select a brand medication, place an order for a brand, which I was shocked by.
Oh my God.
Yeah.
Wow. I was going to say, I don't know of any such relationships, but I wouldn't put it past them. That is really bizarre. I know that there was a great shortage of hydroxychloroquine. It happened, since COVID with the shortage of hydroxychloroquine. That is, wow.
It was recent. It was for a lupus patient, so it was appropriate.
Wow, that's crazy.
Yeah.
I don't know of any such relationships. I'm going to look into that.
Anyway, thanks for a great talk.
Thank you.
We have a question from one of our residents. He says, is Ghassan. He says, thank you for a great talk. What is the current direct role of the federal government does actually play in this entire chain of drug pricing?
So the federal government plays a bunch of different roles. Hold on. Oh, I'm not going to bother going back to the slide. So number one, the federal government is an insurer through the Medicare system. So they function in that way. And they also have a regulatory role over all of these things. And so they have a lot of power through regulation to change all of this if they wanted to. But they also have a lot of power, they have a ton of potential leverage through Medicare that they have chosen not to exercise because Medicare is not allowed to negotiate drug prices. But if Medicare really got in the game of negotiating drug prices, they cover so many people that they would have a ton of power. It's a little bit complicated because Medicare, the drug benefit goes often through private companies, but still, if they wanted to, Medicare could really change this tremendously. And I'm hopeful that will happen.
Thank you. Dr. Radbull says that many health systems generate revenue by leveraging the 340B program. What is the effect or result on the patient?
I have to say, I do not know the answer to that. I honestly, I don't know. I don't know the complexity of that. Sorry, I can't answer it. Sorry, Brian.
No, that's okay. I've been trying to spend the last 4 years trying to just understand the 340B program. So it's very complicated, but it is interesting.
Dr. Korenstein, this is Samuel Seward. A question, pharmaceutical industry by and large is international, and it's my understanding their kind of thinking around a lot of this is related to two things. One is cost of exploration, and the number I often hear is $1 billion to bring a new drug to market. And also that the excess cost in the US countervails costs elsewhere in the world, including what they do for, underserved populations where, for example, we hear about companies providing Ebola vaccine free of charge to whole nations. And I just wondered, that kind of international perspective, that adds a different level of complexity, if you would comment on that.
It does. I mean, I think that's a great question. Thank you for bringing that up. I think that to some extent, those are really real concerns. And to some extent, the pharmaceutical industry is totally disingenuous. I showed you how much money they make. The industry makes a tremendous amount of money. So even though it does cost them a lot to bring a drug to market, those costs are hugely offset by the profits that they make from the drugs they have. And so, the percentage of their budgets that they use to supply drug to underprivileged patients, either, domestically or in other countries, is quite small compared to kind of the size of these companies. So I do think on the other hand, I do think we want to make sure that they're able to do those humanitarian things like they do now. And those are obviously important. But I also think that they don't have a right to make as much money as they make. They make so much profit, and they're making it off the backs of American patients that it just doesn't seem right to me. And so I think those issues all represent real things, but they exaggerate the money associated with them to kind of get themselves off the hook from having to work to control prices in the US. And I would also add, when it comes to branded drugs, they're not necessarily the ones making more money because of the perversions in the system. It's like I showed you, they're making the same amount of money whether they price the drug lower or higher, because it's the rebate driving the price for the patient. So, that's why a lot of the policy solutions have focused on regulating PBMs, because there's this idea that they're really the ones driving up prices. Unfortunately, I think there are different situations for different kinds of drugs in different contexts. But my short answer to that is I think those are real issues, but they can be worked through, and their importance has been exaggerated by industry.
Thank you.
Hi, this is John Gurley. I wanted to ask a question. There's been a big push to start infusion centers across the country to kind of change who's benefiting from some of this. And I just wanted you to, if you could comment on, the concern that some people have that if all of a sudden this is changed, all those investments would now not be in the hospital's interest, et cetera.
Yeah, I mean, obviously hospitals have done what they can to stay afloat. I mean, I don't want to say make a lot of money, because I think hospitals are generally not particularly profitable, to stay afloat, and survive in this crazy system. And so I think there are hospitals that have invested in infusion centers, and I think that they should make money off those infusions, but I don't think they should make more money if they're infusing higher priced drugs. That just seems totally insane to me. I think any reforms have to take into account the transitions, and making sure that things like critical entities like hospitals don't lose a ton of money. But there are a lot of, where I thought you were going with this is there are a lot of transfusion centers that are private, that are just private for-profit businesses. And I actually know somebody who's a physician who was hired by an infusion center to basically oversee for infusions all day long. And they pay her a ton of money for doing nothing. And the reason is that these are all very high priced drugs. So infusing them reimburses a huge amount of money. And I mean, these things are just like mills. So yeah. I think when they're being done by hospitals, it's a bit different, but I think if people are taking advantage of these perversities, it just should stop. And yeah, we may need to give people a kind of a landing pad so they don't get ruined by it. But to me, it shouldn't continue that way.
Yeah, I didn't want to actually touch that because that makes everything more depressing. Especially when we're talking to the residents, I try not to bring that part up.
Well, the residents can be the good guys and not the bad guys.
Right.
Some of us don't have that luxury anymore. We are who we are.
Well, Dr. Korenstein, I want to thank you again. Really, your lecture was wonderful, and also a wonderful way for us to celebrate the many, many contributions of Dr. Carl Henry Hank Knox. I think you've inspired all of us to one, learn more, and also include this in the way we're thinking about our own prescriptive patterns. So thank you so much.
Thank you. It was a real pleasure. Nice to see so many old friends.